Hi, Angela. Going to make my way through some of these questions and answers, and then after that, I'll do a film on the skeletal model. Let's see. So all are good. I really like Gregory Greaves' answer. Question number 6. Of course, the answer was D. I think that makes sense. And I can't even read my writing. I Xerox this, it's too light. Yes, the axis along the PSISs. What that means, it's a horizontal axis. And it's the center of the joint. So if you look at that boomerang-shaped joint that points down towards the hip, it makes sense that it would forward bend and backward bend. One of the most conservative PTs who wrote a book on kinesiology acknowledges that axis and questions all the other ones. So I hope that's helpful. And it is a very small amount of forward bending and backward bending. And sometimes you'll miss it looking at active movement, which is why I do spring testing. In this course, we only teach the hyperextended second most common pattern with respect to forward and backward bending. In the advanced material, which you could consider later on, I would wait 6 months at least. Then we talk about the unusual case in which it is stuck in backward bending. Okay? All right, so the rest of it looked really good. And I do get that the workshop from 2010 is the basis for the DVDs, and my work did continue to evolve. And I understand how the workbook has undergone evolution, and I didn't anticipate then, I didn't even think not to mention page numbers. But I do think that we will refilm this in this year. Just haven't been able to. So now I'm on block 2, number 12. Now, a woman without children, of course, would have less mobility in the pelvis than a woman who had children, but the real case of hypomobility would be a 70-year-old cowboy. Some people think, well, he had a lot of falls, therefore it would move too much. But honestly, those kinds of traumas over the long term end up causing perhaps a little extra motion, but then they start getting osteophytes to constrain that motion, and then they really do lose mobility. Also the age, just by virtue of his age. All right. So number 15, all of the above do qualify as contributing to general hypermobility, and the elbow will look hyperextended beyond the norm. And generalized joint pain, that's probably a little bit of a tricky question because it does depend on the individual. And I think some of these questions really need a little bit of revision. We actually did that. Went through a very arduous process of doing that. And when we had to completely erase the hard drive on our computer, the tech informed me that he did not set up our network on the program that would do serial saves. And we lost months and months of work. I say 9 months, maybe a year. Anyway, you could look at the fifth metacarpal and you can see that mine only goes 30. I am a hypomobile by nature. I have a lot less elastin in my connective tissue, which is terrible because when I take a tumble, a car wreck, something, it really tears things. So not the best thing. And of course, knee hyperextension. The way that I like to test knee hyperextension is on the table. Just imagine this person is laying down. What I do is keep the femur on the table, and I lift the ankle up off the table. And most people will only move about 5 degrees into hyperextension, but the hypermobile folks will certainly more. So I hope that's helpful to you. And I apologize for the differences there in the questions, that some of them really do need reworking. And a couple of them are designed to just kind of see where the person is at theoretically, so it doesn't necessarily mean it relates to an answer in the workbook, but kind of an overall perspective. So in truth, relaxin, the hormone, we hear too much about relaxin, but it acts in concert with the other hormones, especially estrogen. And that's how it is. Is it in Folger's coffee? No, I drink coffee, and no, it doesn't make me mobile. I mean, it does, but not my joints. I wake up, then I'm somewhat mobile. At least when I walk, then I can walk at least like a little bit less like Quasimodo. Okay. So I hope my notes made sense on block 4, number 6 on type 1 in-flare, out-flare. So a type 1 in-flare, out-flare means a right in-flare and a left out-flare. And please understand, all the predecessors were there in the most common patterns. So it's very predictable that this will be the next thing you find. Now sometimes I correct an anterior ilium, maybe a posterior, and the flare goes bye-bye. But other times it's still present and therefore worth treating. And you can only evaluate it on the side that has an out-flare, and that'll be blocked when the person is prone and you spring them at a 45-degree angle. I used to do an in-flare spring with people supine, and I got so much bad data, I quit doing it. And basically, people can weight bear on the sacrum, and it will be a false negative because it doesn't really isolate the SI that much. So that's the reason for that. Okay, so I didn't understand that your essays would be at the end of the document. I thought those were specific questions that you had. I hope the drawing under the torsion section is helpful to you. And I hope the writing is clear enough on number 8. And what it says is, for example, you can have a left rotation about a right oblique axis. In my terminology, that would be described as left lower quadrant prominent and stuck. And so in the drawings there, I mark the areas that would be prominent and stuck. And you would simply name it. For example, this is the most common kind of torsion, and you would name it left lower quadrant, prominent and stuck. Okay? In my opinion, people confuse it when they talk about a flexion dysfunction or an extension torsion, whatever. I find this terminology makes a lot of sense. Okay. So I'm going to just look back at that camera, look through it, and just see if you can really see me. Yeah, I think you can. Pretty good, yep. Okay. So in your first paragraph under treatment, it would be a left side force of the pelvis to the right. The best way to describe these kinds of movements would be to say left to right, and then the person knows that you're starting on the left side and you're pushing it to the right. Okay? Let's see. I was a little confused when you mentioned a spring test on the pubic joint, because I don't think that's in the workbook. I used to do it, I still do it habitually, but I don't teach it in this basic work. I just feel like too many people can get hurt. You know, we have a classroom full of 30 people in different skill sets, and I just don't want them springing a tender area like that. And it begs the question of, in our culture, you know, what are you doing down there and all that stuff. So the spring on the ischium, the PA spring, is the most relevant one. But I will look back in the workbook and see if there's something there that hints at doing an AP. I think it says, I think I clarified it, but I'll double check. All right. Now, when the client is supine for a left sacral rotation on a vertical axis, a roll-up towel doesn't work. It has to be rolled up on a magic marker. And so I would let the marker dry out, or I would tape tape it severely so it's not going to leak. Anyway, and then roll it up in a face cloth, a washcloth. And you can put rubber bands or you can tape it. We make a really nice one that's in the product section of the website. And it's rubber foam, very comfortable, and it deforms a little bit and thus becomes comfortable. And it's very long lasting, etc. So going down to the next treatment of left sacral side bending, it's the easiest move you'll ever do. And I tell you, one glide is probably sufficient. Habitually, I do it 3 times. Always works. You'll sometimes feel a click there. It could well be side bending at the L5-S1 facet. No one knows. No one's done the research. It's very difficult to do that research. So then the spring test is not at a 45-degree angle. It is a pure anterior spring, okay? And the way that I'm teaching that now, and it has not made its way into the video or workbook, is in the workbook you see me using the ulnar border of my hand. Everyone has trouble with that. They end up being in the wrong place. I tell everybody the middle here has to be inside the fascia, okay? And then they just push towards the front of the body. Let me get a better view on this anatomy here. So you always have to isolate PSIS and then put the heel of your hand there, okay? But I really don't like that. Just too many persons in the class don't get it accurately. So what I'm teaching them now is to find the PSIS. So then you take the very middle of the palm, that nice indentation there, and you slide off of it onto the sacrum, and then you just take up the slack gently and spring. Then all you have to do is slide across to the other side. Okay? One thing that also has not made its way into the film or into the workbook is what I teach people to do is get a safe magic marker, the water type, the ones that are safe for use on people, okay? So what you do is you find the PSIS and you put a little X an inch lateral to it. And you can do just one side. That'll, you know, even with these twisting and such, the other one is not going to be very far away. And if you have a little X here, you know that the right PSIS is here. The left one is around here, and you just circle around with your thumb a little bit and you'll find it. The other thing we do is we find the shelf of the ilium. And again, if you mark it right there, then you're going to have the marker on your fingers and not on the person's body. So what you do there is just mark it slightly medial or slightly lateral. And then you don't have to do all this repeat palpation. Where's the shelf? Where's the PSIS? Blah, blah, blah. Okay? And the rule of threes is a very valuable tool for finding landmarks. You divide this pelvis into thirds. You can easily see the gluteal crease, get under the ischial tuberosity. And then you get on top of the shelf, and then you just create a lower third, an upper third, and of course the middle third magically appears, if you will. Okay? So what is at the upper third? Well, of course, the shelf is at the upper part, but at the lower line, you're at the PSIS. So it's a beautiful way to find the PSIS. The lower one defines the area of the ischium that's flat that you'll be springing. But if you keep going, it'll help you find the ILA of the sacrum, okay? The inferior lateral angle. And in between those two critters, if you connect ischial tuberosity, the medial portion, with that part of the sacrum, and you can walk across and dig deeper and deeper, you'll find sacrotuberous ligament. Beautiful techniques. I'm really, I really like them. They make our job a lot easier. Okay, so that's that. And it looks like I mixed up paperwork a little bit, maybe. I'm actually now on block 6. Number 1 question is, I know that this was in the section on upslip, downslip, but this is one of those questions where we'll just kind of get you to think about the previous sections also, and all of those in fact are true. Okay? Okay? And then number 5, regarding upslip, all of those are correct. If you have any questions about that, please let me know. And then number 8, definitely, if you have a combination pattern of an upslip with a posterior ilium or an upslip with a anterior ilium, or a downslip with those. It's like you just can't, you know, here's the rotational thing, but then it slides up, so you can't really reduce that pattern. Now the upslip downslip can be really subtle, and you might miss it on the initial eval. The way that it announces it to you is the fact that people come back and the pattern is still returning, and then you ask them, well, did you do the exercises I taught you? They go, yeah, I did them this morning, and it reasonably should, these rotations reasonably should correct rather quickly. And if they don't, there probably is a subtle up or down slip, and then you'll test for that specifically and find out if that's true. Of course, you always have to do the sequence of things, you know, testing as it is laid out in the workbook, testing for hip rotation, hip extension, pelvic side glide, that whole thing, the assumption being that all those things have been addressed sequentially. Number 8, okay, that is the answer to number 8. All right, and now I happen to be on block 7. I don't know why I got these mixed up, but I did. Number 3, I don't know that the hamstrings and heel cord are already long. That seems, in my opinion, a hypothetical perspective, a theoretical perspective, and I'm sure that you test those things, but with the most common pattern, I really do find tightness in all of the physiological extensors. And I think if you think of the shift to the center of mass being forward, that might be helpful. And then number 4, all of the above. You would have some hyperextension at the thoracolumbar junction, but you would have to flex somewhere. So you would flex at the cervico-thoracic junction and down probably as low as T5. And you'll have upper cervical hyperextension and a forward head. So let's see. Now I'm on block 8. Actually, the workbook does talk about a common lumbar motion dysfunction, and that follows right after the in-flare, out-flare section, in which L5 follows what the pelvis does. And this whole common pattern is much like a right-handed golf swing. So they have the club way up high above their right shoulder and they swing to the left and the pelvis gets stuck there. Now, I would be so curious to know if you see things differently where you are, given that the steering wheel is on the right side of the car, and so they're going to get in and out of the car differently. That would be a fascinating thing to know. So when you have a chance to evaluate several people, please let me know if you in fact see the opposite pattern per spring tests. So that would be very interesting. In fact, we'd have to have a long conversation about that. And gosh, we would have to create a whole new section on the most common pattern for countries where the driver's on the right, but I've never been able to do the research, so I don't know. But what you can do is hold up the sheet and you flip it over and hold it up to the light, and that reverses the side of the body. A lot of people don't understand that L5 will follow that whole pattern in the sacrum and with the ilia. And it's the way that manual therapy is taught. It has these rules and regulations that actually confuse people. And what I always say is test it. You know, if you think it's going to do the opposite thing, if your training tells you that, go to the body and test it and find out if it really does do that. And if it does the opposite, that person has a very unstable spine, and I hardly think that they walked into the clinic. All right, great comments, really great understanding demonstrated in your answers. And I'm on the pattern of anterior ilium, and let me back up and see what that is. Okay, so when client is prone, if you want to see, you think they have a posterior ilium, I'm sorry, scratch that. Person has a right anterior ilium. So the spring test is done at a 45-degree angle in the sagittal plane. Okay? It is not lateral. And I've got to check the workbook. I hope there's nothing in there that causes them to believe that. It's a pure movement, only 45 degrees that way. Just think of following the slope of the shelf. Okay? And then when you flip them over, the orientation of the landmark is very different with relationship to the joint than is the front landmark. There's not a lot of ilium available. Of course, there's just by design. Usually, if the PSIS is here, you usually got a thin slice of ilium and iliac shelf. So you need to be very conscious about springing right on the shelf, not on soft tissue, but right on the bony part of the shelf. And it is a pure forward spring towards the floor. Okay? I hope that is helpful. And I used to always tell people you must be lateral and above the PSISs, and semantically it didn't work. So what I tell everybody now is find the shelf and spring right there on the bony part thereof. And that seems to work better. I don't know why. Now when you're doing the self-treatment, would you please review the section on the therapist-directed treatment for a posterior ilium? When you palpate here, it's really light because you're just feeling to see when the ligaments tense, you know, and when the ilium starts to move. And you certainly don't want to hyperflex, as you noted. With males, you're not going to make 90 degrees, but most females you'll make 90. And some you actually even need to go a little bit further than that. I hope that clarifies. Type 1 end flare. They will have blocked mobility on the left. And the same thing for an out flare. And I treat both at this, you know, together in those 4 different exercises. And I understand the technique you use, and I think that's fine. I would just say that if you ever have a difficult case that doesn't respond to that, then you would find those flare exercises to be very helpful. But I really like the passive glides of those techniques. I really like the stretches as well, and I developed these so long ago, and I had a client that didn't respond to the osteopathic muscle energy technique, so I went home and thought about every reasonable thing that I could do. And I appreciate that a lot of PTs are, you know, strengthen, and I'm more of a, like yourself, let's release these restrictions that are inhibiting strength. And then strengthening becomes easy, and it even becomes natural. If the pelvis is moving normally and the hips are moving normally, they're using those muscles in a fairly appropriate manner with normal ADLs. So I'm not against, you know, strengthening programs. I'm just saying that there's a nice roadmap to segue into that, and I think we're in agreement on that. So let's see. Okay, so when you're palpating for a flexion movement dysfunction, I'm going to have Karen come and film me because I don't want to mess up here, okay? Camera's going to keep running. I need you. Film is running. You're going to follow my thumbs, okay? So in this hypothetical person who's sitting on the table, they can forward bend a little bit, comfortably so. I like to have the table down low and their feet on the floor. They feel more confident in that. And what's nice is the lowest lumbar segment is a pretty honest segment, meaning that the spinous process is fairly in line with the transverse process. For springing, you can do a spring test on one side, so I'm springing right to left motion. If the vertebrae is rotated to the left, okay, the front of the vertebral body goes left. The rotation, of course, always named for the front of the body. That would take spinous process to the left, okay? So if I twist this spine to the left, you can, if I twist the whole body, the vertebrae to the left, then you can see the spinous process goes to the right. Therefore, when you come here and try and spring it, it would not move. And if you came and did a spring here on this side, it would move. Okay? Some people talk about a laminar contact here. You speak of a facet contact. It's so deep, of course, we can't really feel the bone. But if you're even a little bit further away from that, then you're going to perceive something farthest from the axis if you're thinking of a central axis up and down. So I recommend palpating laterally in the region of the spinous process. Now if you were working in another area of the spine and you're not really sure where the spinous process is relative to the transverse process, don't worry about it, because you can come and spring spinous processes and you'll find the one that is restricted. And then you can palpate across and just go up and down a little bit, and you're looking for the area where there is the greatest asymmetry. Okay? Now, of course, these critters are wider in the lumbar and they taper a little bit, and then they get quite narrow in the thoracic spine, and the rib joints come here, and you can feel that big knuckle, the tuberosity of the rib. You should be able to feel coming off that spinous process onto the rib. If someone is somewhat slender, you could spring the rib a little bit with a broad contact here to see what moves and what doesn't, and that which doesn't would be the transverse process, medial to that which moves. And of course the neck also has rather short transverse processes, and up here they're called a transverse tubercle. So I hope that's useful. Getting back to, so you don't really have to test the person's rotation or side bending. It doesn't give me a lot of useful information. Basically, once I have the person flex, then I can determine, because my left thumb, if I'm palpating with both thumbs as the person bends forward, if they have the most common pattern at L5, then my left thumb is going to move towards me because they are rotating. Okay? So you put the person in flexion and you'll be able to know if there is a rotational pattern. Now you want to palpate up a little ways always. If you're in the middle of the spine, you want to palpate up a bit and down a bit. Find out if it's a whole group pattern. Okay, if it's a gross muscular response, if it's a scoliosis, a fixed deformity, etc. A little tricky sometimes inside that you can have a specific joint dysfunction, even though there's this whole pattern. I wouldn't worry about that right now. I hope that makes sense. So you just put them in flexion and you'll be able to find out if there's a rotation. Okay? Then you put them in extension if there is none, and you do the same thing, palpating with the thumb on each side in the region of the transverse process. And I think you'll find this to be very effective. So then you know that either in flexion or extension there is a rotational pattern, especially at one segment. Okay? If it's a one segment problem, such as in the most common pattern. So at that point, then you can test side bending, because side bending is you can test side bending at that point. Have them side bend to the left and look at what happens to your thumb, and then have them side bend to the right. You might actually feel one thumb move away from you, and you might feel the other thumb come towards you. Now, if I had to make an assumption, if the person said, you got 10 seconds, I have to run, do your thing, if they had what I thought was the most common pattern in flexion, in which L5 was obviously rotated left, I would make the assumption that in flexion I'm going to rotate them to the right, which is a correct assumption, and I would go ahead and have them side bend to the right. If I'm wrong, I'm not going to hurt them, but when they come back, the pattern will still be there, and at that point I could, test it more specifically. So when you have a single segment pattern returning, especially at L5S1, it might be that the side bending component is subtle and it was just misdiagnosed.